the topic I was assigned was pediatric femur fractures. So I'm going to focus specifically on femoral shaft, and I'm going to give you my idea about how to use AAOS guidelines, and we'll talk about that. But let's talk about the idea of femoral shaft fractures first. So this is common, and complications really are not so common, all right? And I feel like some of the complications are because there are so many different ways to treat them that no one really can decide on what the best one is. So in that vein, that's what this talk will be about. But the complications that most commonly happen in femoral shaft fractures in kids are shortening, malunion, and then a very distant third is delayed union. So our shaft fractures, really, it's not a healing issue. It's a matter of getting them lined up, not short, and comfortable while they're healing. So this is where I'm going to get on a soapbox a smidge. So AAOS treatment guidelines exist now for several different things. There were an attempt to use evidence-based literature to create guidelines that can be applied clinically. And I feel like this one is a good one, but I think what I want to do with this is point out what the pitfalls really are of when you're looking at guidelines and how to use them. So the basic treatment guidelines for children are this. From 0 to 6 months, we use a Pavlik harness for almost all femoral shaft fractures. From 6 months to 5 years, we use what's termed an immediate Spica Cast. From 5 to 11, elastic nails. And then from greater than 11, we use elastic nails or lock nails. Now, this guideline in particular avoids or misses two commonly used techniques that you're going to see us talk about a little bit in their usage. But the submuscular plate falls into this category fairly commonly also, although it can be drifting all the way to here or all the way out here if you want it to be. And then X-fix is still an option, okay? So if I'd given this talk back in 1995, I would have even not mentioned elastic nails. We would have had X-fix as a surgical option for these kids. So it's out there on there, but the guidelines are not these. So let's go through this a little bit. So again, not age, but size of child, so weight matters, canal size matters, mechanism matters, because there's a lot of fractures that I would be willing to treat in a cast, except they have 3 other fractures or they have a lacerated spleen or some other reason not to. And then one I want you to focus on as we walk through the cases, because this really will be a case talk in a second, is it seems that when people make mistakes about fracture care in femoral shafts in kids, it's not recognizing length and stability. Okay? And length and stability can be as much as just overlap from soft tissue injury, or it can be comminution. So when you're thinking about the treatment guidelines for the kids, you need to take that into account almost every time. And if you look, when I'm talking about the mistakes that are made, often that's a problem. So let me just briefly go through this. So everybody knows what the Pavlik harness is, correct? I assume this is the device designed for DDH. And it turned out, and I think the first time I remember reading about it was in the early 90s, maybe late 80s, it actually functions quite nicely as a very simple Spica Cast in some regard, okay? Because if you think about what a fracture Spica Cast looks like, it's flexion and a little abduction and almost a sitting position, so it fulfills that, but it's Velcro. So it can be taken off, the kids can be washed around it, their skin can be checked, and it turns out in little people, this is actually a great option. I will say caveats. One, their skin around their swollen femur, especially in their flexion crease of their groin, can be a problem. 2, parents need to know pain control isn't great, okay? They really hurt for a week or so until their callus is settled in, then they're fine. And then 3, and actually I was nervous initially when I first started using this technique, but some of these kids are abused, right? We just talked about child abuse, but if you're treating a femur fracture in a kid under 6 months of age, there's a fair chance that there's abuse involved. So I always am a little bit hesitant to send home a Pavlik harness with a family that I don't know, or a foster family. So we spend a little more time educating them, and I do see them literally every week while they're in their harness, just to make sure that things are going okay for this age group. The 6 months to 6 years is interesting because this is typically what we would treat with the immediate Spica Cast. So everybody remembers that, but immediate by definition meant the next day pretty much. And what we would do is we would use a 1 1/2 or a one-legged Spica, and we would shoot for overlap. We wouldn't go for anatomic, okay, and we still don't. And the reason is, and Dr. Rakesh talked about it a little bit, but there's a subgroup of kids between ages 2 and 10 who will overgrow an average of about 1.5 to 2 centimeters just by virtue of having had their fracture, okay? And it's so reliable, actually, that we will rely on that when we're putting these immediate Spica casts on, because if we put them out to length, actually, the fractured leg can be the long leg. So in general, we shoot for this shortened version. We will take up to 20 degrees of angulation. And the biggest issue, if you've ever been to St. Chris or other pediatric centers, is the poopy cast, okay? Patient care in the Spica cast is difficult for families. And for some people, it has driven the age limit for flexi nails down below 5 and 4 and 3 because of the concern for that. So we'll talk about that in a case in a minute. This is the biggest change, this age group. Okay? So anybody that trained before the advent of flexi nails being used in this country, in this city in 1998 was the first time we used them. They were a part of a beta center study that CHOP was involved with, and St. Chris also used them in 1998. So that's the first time we used them. These are similar to, but not the same as Ender's nails, if you guys remember what they are. Ender's were stainless steel and had an eyelet. They came in sizes, and you had to basically predict the size. Flexi nails are a whole different ballgame. They come in different sizes of diameter, so they come from 1.5 to 4, classically, and they're titanium for the most part. There is a subgroup of people that used a stainless steel version, and we'll talk about that maybe in a second. But the typical indication for flexi nails are those test question indication: middle, third, length, stable fractures in children under 50 kilos. Okay? So taking a test, that's the answer. Very good, very, very good track record for these. Then over 11. So this is another thing that's evolved, certainly in my career. So locked nails traditionally were designed for the piriformis fossa. Except when people used them in children, they learned that putting a locked nail through the piriformis fossa caused 2% of them to get AVN of their head. Okay? It was actually at my fellowship where one of my fellowship directors wrote the first case of it. Okay? AVN is because you make a huge hole in the piriformis, and there's an end arterial, I think it's the medial femoral circumflex, that gets bagged. So what we did was we said, well, let's move it more laterally. So the modern era technique for locked nails in children who have open growth plates is to use what's called a lateral entry nail. This nail is not tip of troch, it's actually more lateral, and the nail is designed, as you see, to make a curve at the top to make the bend. Okay? I feel like this is my favorite new implant maybe in the last 10 years, okay? Because this really allows us to do length and stability, proximal, distal, recon style, all kinds of fracture patterns with a single device. The dilemma is, of course, that the companies haven't made them small enough yet, so we can only use them in kids whose canals are bigger than 8 millimeters and have a big enough proximal femur to take the opening reamer. So that's the setup, okay? So I wanted to talk about complications because this is what we see. So this is a 3-year-old boy. Fell off his couch a week ago, and he was taken to the OR by somebody else and then lands in your clinic with that x-ray. And if you look at that x-ray, I guess it's too hard to do a question. Does everybody think that's acceptable or not? Who thinks that's acceptable? Who thinks it's unacceptable? Yes, I think acceptable is probably the answer, right? It's a little short, it's not angulated, but the problem is this. So this is our classic dilemma, right? So this is the problem. They actually didn't come in because they were doing their follow-up check. They came in because they had urine burns on their cast. So one of the complications that we deal with immediate spica casting, even though it's an ideal technique, is the concept of hygiene and care. So you wind up having to shift gears, not so infrequently. Often we can get away with a temporary splint and then put them back in a cast, but in this case, there was a concern that this skin required much more than a couple days of skin care. So in this age group, and you're talking about a 3-year-old, you're left with not a ton of options. You can go back to traction. Elastic nails certainly are an issue, or a possibility. You can always X-fix, right? Always X-fix. Or you could wait till the skin's better and put them back in a spica. Okay? So in this case, and I'm not advocating this, but I think this was a good choice for this kid. Flexi nails were put in. Just a couple technical things if you've ever done these. How many people have done flexi nails and femurs? Okay. So as the bone gets smaller, it gets a little more challenging, but it actually gets easier to reduce the fracture pattern, okay? So this is a technical exercise for the most part for these guys to get reduced, but just to pass a bone through a canal that's only 4 millimeters. So medial pin, medial rod, lateral rod, and you got to remember this is a classic mistake. So pay attention to where things are. It seems like it shouldn't be that easy to know you're out, but sometimes you don't know. You made your holes exactly where you put them, your residents putting the nail in, and all of a sudden they realize that they popped out the back or were never in the nail. But eventually this was fixed, okay? So when I show this pictures, this is controversial for us, but this has become, for some places, a standard of care now for kids over 3 or 4. So just to give you a sense, when you read literature now, you're going to see this. But this is a bailout for, I think, immediate spica casting, but I still think there's a role for immediate spica casting. Okay? Next case. Another concept. 11-year-old boy wrestling with his brother, 77 pounds, and has that fracture. So it's curious. You would think wrestling with your brother is not so high energy, yet that looks common to it. Okay? How many people want to elastic nail this? Anybody? Anybody want to X fix it? Got one. Anybody want to submuscular plate it? Anybody want to lock nail it? Yeah, I would have knocked nails, but here's what happened. So this is a case of someone that sent this to me. They got flexi nails, 3/5 titanium nails, reasonable alignment. And what do you guys think? What do you think is going to happen? What's the most likely complication that I'm going to show here? What do we think? Length instability in flexi nail is going to lead to shortening, right? So predictable shortening. So if you're going to use flexi nails in an in-between fracture pattern, and I would argue comminution or even a long oblique fracture is a questionable fracture pattern. You have to either try in the OR to stress and prove that it's okay under fluoro, or just watch them carefully and say, you know what, maybe I'm going to miss, okay? Because even a Spica Cast overlying your nails won't fix length stability, okay? So predictably, this kid had this happen, and this is my least favorite complaint from the families. The kid's complaint is, I think I feel my nail sticking through the skin, okay? Nails don't migrate unless they shortened or angulated, unless the limb shortened or angulated. So if the medial nail in this case was more protruding, so something happened, and actually when this was scanogram, this was 3.5 centimeters short. Okay, so it rode up the obliquity, too short now, and you're left with 3 weeks later with the nail protruding and you have to do something, okay? So the assumptions. So what are the assumptions here? This is another, you can debate this all you want. I personally would have pulled this out to length and just put taken those out and put an X fix and been done with it. That's an option. This person chose to do this. So it worked, right? So just to show you what this means. So I want everybody to understand what a submuscular plate really is. This is a classic way to think about what a submuscular plate is, right? It's an internal, external fixator. And that's what this did here for them. And it held them out to length, and the kid did actually fine. A lot of hardware, but did fine. So there is a way to salvage shortening. You can choose how you want, but remember, length instability is a huge problem with flexi nails, and it's probably the most common thing that we see as a mistake. Okay? Another thing, and actually I talked a little bit about this at the breakout session, but the tweener trauma patient has become a big topic for us. Okay? The kid who's not a kid quite yet, I mean, not still a kid, but not quite an adult. Okay? Maybe growth plates are almost closed, but not closed. Size of an adult, but not an adult. So here's a classic one. 15-year-old boy, front seat passenger MVA, 160 pounds, and that fracture. Okay? So in anybody's trauma center, who's going to do a submuscular plate? Who's going to do a nail, regular lock nail? Anybody going to try an X-Fix or flexi nails? So to give you an idea of how people and how things evolve over time. So there is a subgroup of people who are experimenting with the use of flexi nails in bigger kids. And what they're arguing is two things. One, if you upsize the nail, you get a little bigger stability. But two, stainless is more rigid than a titanium. So the reason that, and I've seen this in two different places. The developing world, where it's just easier to put these in, and then for speed. So in this case, there was a concern that the kid had an open forearm and a concern for both bones that was going to be a problem, and they thought this was faster. And that was the outcome. Okay, so 4 or 5 stainless steel nails. We just said most of the flexi nails are not ideal for length stability or weight. So predictably, this happened, okay? So I would argue flexi nails need to be, and I've learned this over time, if you're going to use your flexi nails, you really should stick to the indications as best you can, right? weight and length stability really are keys to making a flexi nail work for you. All right. Now, fortunately, you had a good bailout here, right? This is an easy bailout. You just take these out and put a rigid lock nail in, and you know, if concern for time was an issue, then this was a fine way to bridge it. All right. But in the ideal situation, this probably would have been best done primarily as a lock nail. All right, so another topic I'll briefly touch on. I will admit I don't have a huge experience, but this is a case that somebody sent me. So 10-year-old boy struck by car has that fracture. Okay? So if you're using your algorithm, you're gonna look at flexi nails again, right? Or something else, but this is not a flexi nail case for lots of reasons, right? So I didn't harp on this, but if it's not middle third, how far toward the ends can you go with flexi nails? All right? So you got to you have to have a start point. So if it's very distal and you can grab from proximal to distal with an anterograde approach, fine, but you still need something distal to grab. Okay, and the same goes reversal, right? A very proximal fracture needs something to get fixation in. So probably distal junction of proximal middle third is the best you can do. Okay, this one doesn't fit any real great criteria. You could X-fix it. You can name a lot of things, but there's really not great choices except for really one, which is this. So let me tell you about pediatric trauma that you got to remember. Okay, this kid was autistic, all right? And if you've ever been at my clinic, you know that most of the kids aren't really normal. Like, they're just not. There's a whole lot of trauma patients that aren't normal. There's a lot of neuromuscular kids that get fractures. So this kid actually was put in an immobilizer because his mom said, oh, he'll be fine. And he did what neuromuscular or autistic kids will do. Especially if you don't have adequate fixation, they will do this, okay? So I've had that happen with inadequately sized flexi nails, and now in this case with a plate. So one of the warnings I have if you're going to use not completely stable fixation in kids, especially kids that can't comply, is I do add a Spica Cast often to kids like that. Even if it's a one-legged belly band Spica Cast, you leave it on for 4 weeks, they get enough callus to control a little bit better any deformity that might happen if they don't abide by your rules, okay? So this was fortunately salvaged simply, one of my friends did this actually, with bending irons, and then what do you think he did? He added a Spica Cast, okay? So another thing about pediatric fractures is we don't get the same stability that you guys do with your lock nail constructs. We almost never do. And even if you think you do, you don't. Okay? So I tend to I really over-treat them a little bit. If I'm any concern at all, I put them in a belly band, one-legged Spica Cast, protect them for a little bit, bend their knees so they can't walk on it. It tends to work fairly well for them. And then one last case, and so we have a great experience with these flexi nails. We're still good at them, but technical problems can bite you still, okay? So here's a case of a classic indication, right? Should have been easy, should have been a chip shot. X-rays suggest a struggle. So flexi nails, if you remember the technique of flexi nails, and we talked about it at my breakout, ideally at the fracture site you have maximal spread, okay? And ideally you have about 80% of canal fill between two of the nails, okay? This case, the nails got twisted on each other. You see it? So when they were putting this in, sometimes the nails crisscross as you're putting them up. And what happens is it winds up being this sort of curly-cued single piece of metal, okay? And it completely ruins the whole concept of flexi nails, which is sort of balanced suspension fixation within the tube, okay? So predictably, and of course in this case, another issue with flexi nails that we see, if you look carefully, there is some distraction. So I often say, well, distraction will be fine because if you let them walk a little early, they'll compress it up, but sometimes it's not, okay? And you see it mostly, I will tell you when you see it mostly in the forearm. If you distract the ulna, for example, with a flexi nail, it's not going to heal, okay? So pay attention at the very end. Often the distraction happens because you have to tap the nails up to get them subcutaneous after you cut them off, and you didn't pay attention to the fracture site. So this bent and got a deformity, okay? So we still see these. Flexi nails aren't perfect, and the people report about 5% of malunited fractures with flexi nails, not just shortening, but malunited, okay? And in my hands, at least, when we see them, it's almost always the implant was too small for the size of the child, okay? Or the choice, the fracture stability wasn't wasn't adequate for the kid. Okay? Boy, we're running out of time, huh? All right, and this is what happened. So they had an osteotomy. So to summarize, femoral shaft fractures are relatively straightforward and common, and the algorithm works, but there are definitely parts of the algorithm that you have to understand that don't fit the algorithmic pattern, because mostly in our world of length stability or patient non-adherence to your protocols. Okay, so again, my comment is overtreat and think very, very carefully about when you use flexi nails. Okay, questions?